Greetings, everybody. Welcome to part 25 of our internal medicine review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button in the upper right-hand corner. I appreciate all the contributions that I can get to help offset the cost of these videos. $1 a month goes a long way. So thank you to all those of you who are considering, and a big thank you to those of you who have already donated. All right, let's start with question 1. We got a 70-year-old woman who presents to the clinic accompanied by her concerned son. The son says that over the past year, the patient has withdrawn from many of her social activities. She used to enjoy a senior social group that met every week and volunteering at the local elementary school helping struggling kids read. The son says that she doesn't call him as much as she used to and has a hard time following conversations. She will smile and nod and not remember what they talked about. The son says, I was telling her about my son taking his first steps, and a few minutes later she asked if he's walking yet. The patient says that she feels fine and is occasionally tired. She says that she's recently taking up crocheting. She says that she sleeps 6 to 7 hours per night and doesn't smoke, drink alcohol, or use any recreational drugs. She has a history of peptic ulcer disease and hypertension, which has been well controlled for many years. Medications include lisinopril hydrochlorothiazide, cimetidine, omeprazole, and a daily aspirin. Vitals are within normal limits. BMI is 24.9, down from 25.2 1 year ago. Which of the following is the most likely diagnosis in this patient? A, major depressive disorder, B, Alzheimer's dementia, C, presbycusis, D, medication adverse effect, or E, normal aging. Okay, so let's go ahead and answer this question. So it is presbycusis. This is age-related hearing loss, and it is in particular a gradual, symmetric, sensory neural hearing loss. This affects 50% of people by age 75. So it is very common. All right, let's take a step back and look at this woman. So the first word you may have been drawn to was withdrawn. And anytime you hear that a patient is withdrawn, they're not doing the things that they used to enjoy doing, the immediate first thing you should be thinking of is depression. And I do hope that when you were reading the beginning of this question, depression did cross your mind. Depression is very underdiagnosed in the elderly, and so it is very important that you look for that. But when we look at what's going on with this patient, remember, you diagnose depression in the elderly, you still have to meet those CIGY-CAPS criteria. So we don't see any change in her sleep. She's getting enough sleep. She feels fine. She doesn't say she's got depressed mood. She's not having any guilt. She's not having any change in her energy as far as we know. Her interests are different, but nothing as far as change in energy. Occasionally tired, that's not the kind of fatigue that we would expect to see in a mood disorder. I mean, she's 70. Come on. Give her a break, right? Her appetite, as far as we know, hasn't changed. I mean, her BMI's gone down a tiny, tiny bit, but 0.3, I mean, that's nothing. So she doesn't meet any of the criteria for major depressive disorder. Alzheimer's dementia, that's a diagnosis of exclusion. Now, the way that neurologists often explain this, or at least the way it was explained to me, was that normal forgetfulness is when you forget where the keys are. Alzheimer's is when you forget what the keys are for. Okay, so that's not going on here. She's not having any problems in her daily life. The only problem that she's having, all of these problems, can be attributed to hearing loss. Okay, she liked going to her senior social group. Well, what do you have to do in a social group? You have to talk. You have to hear people. She liked going to the elementary school, teaching kids how to read. Again, you have to be able to talk and you have to hear them. Kids are really quiet. She talks on the phone. She smiles and nods, and she doesn't remember what they talked about. Well, could be dementia, but it could also be that she didn't hear. She forgot what her son said about her grandchild walking. Again, could be chalked up to not being able to hear it. All right, so we don't see anything else dementia related. We don't see that she's forgetting names of her kids. We don't see that she's getting lost in her house or in her neighborhood. We don't see any of those concerning signs. Medication adverse effect. Well, there is some evidence that some of these H2 blockers can raise your risk of dementia, but again, this would be a diagnosis of exclusion. And then normal aging. So yeah, this condition is normal in aging, but the effects that it has is not normal. Okay, so my grandma has presbycusis. She sits in her room a lot, but she also does get out and enjoys stuff. She doesn't like having a hearing aid. She doesn't want to have one. And if she doesn't want one and she's okay with that, then, that's fine. We can consider that normal aging. But for her, she's withdrawing, and that's not considered normal. So this is not normal aging. This is presbycusis, and we can treat it. Now, what would be your next best step in the management of this patient? Audiometry. You got to confirm the diagnosis, and then you will refer her to be fitted for hearing aids. Okay? So really as simple as that. Now, let's correlate this to pediatrics a little bit. So, if you have a child, they could give you in a vignette where they've got a language delay. Maybe they can only say 10 words and they're 2 years old. Or maybe they're not paying attention in class. It's being chalked up to a behavioral problem. Or they're having learning difficulties along those same lines. And you might be thinking, well, maybe this is, intellectual disability. Maybe this is autism. Maybe this is ADHD. Maybe it's all these other things. Or maybe it is hearing loss. And so you always have to be thinking about that with child patients. When you hear these abnormalities that could be chalked up to just not being able to hear, not being able to engage, next step, audiometry. Okay, audiometry. And you can exclude hearing loss just based on that. And as a matter of fact, now in schools in the United States and elementary schools, they do mandatory hearing and vision screening. They've been doing that for a long time. Even when I was a kid, I remember getting to go do that. You got to skip out of class for a little bit. So you should know the difference between conductive and sensory neural hearing loss. All these down here are common on your exam, so you should know these. Just know what kind of sets them apart. Otitis externa media, often they'll have fever, redness, cholesteatoma, little pearly mass behind the tympanic membrane. Worse in pregnancy, can come on in pregnancy. Trauma, look for the history. Cerumen impaction is going to be evident based on otoscopy. Tympanic membrane perforation, ditto. Presbycusis, we saw it here. Meniere's disease, dizziness. Barotrauma, look for a history. Scuba diving, air travel, something like that. Acoustic neuroma, tinnitus, look possibly for a history of genetic disorders, and cerebrovascular ischemia, that's a stroke. So there's going to be other neurologic signs. Okay, so that's just going through that just from the top of my head, how you can differentiate those things. Know how your Rinne and Weber tests work, medium to low yield for your exam, but it does come up. All right, so here's your anatomy. This is your inner ear here. Anything in the inner ear is going to be sensory neural hearing loss. Outer and middle ear is going to be conductive hearing loss. And then this is just kind of going over what I talked about a little bit. So then notice there's some other things like sensory neural loss from certain drugs, particularly the aminoglycosides you need to remember. Cisplatin, remember Chemoman. Here's your C's for the ear, cisplatin. Okay. And then here's the Weber and Rinne test. Okay, so we spent enough time on that. Question 2. A 27-year-old prima gravida presents to the clinic for her annual physical exam. She's currently 9 weeks pregnant and is seeing another physician for management of her pregnancy. Before the appointment ends, she says, "My little brother, my nephew, and 2 of my mom's brothers turn yellow when they get sick or eat certain foods. This doesn't happen to me or to anybody in my husband's family. What is the risk of my baby having this? Pedigree is shown. Which of the following is the best response to the patient's question?" I'm going to show you the pedigree, and then we'll come back and look at the answer choices. Okay, so here's the pedigree. I made this all on my own. Aren't I a good artist? Okay, let's go and look at our answer choices. You can pause here, see if you can figure out what the inheritance pattern is. Okay, A, the total risk is 12.5% and your baby's sex plays an important role. B, the total risk is 50% and your baby's sex is irrelevant. C, since your husband doesn't have a family history, the risk is minimal. D, since this doesn't happen to you or your husband, the risk is minimal. Or E, we can't possibly predict as this is a sporadic condition. Okay, so let's take one more look at our pedigree here. And usually when you see arrows like this, that's referring to the patient. Okay. All right, let's look at our answer. Here's your answer choices once again. Our answer choice is, the correct answer is that the total risk is 12.5%. Now, how did we get that? First of all, what is this condition here? My little brother, my nephew, and two of my mom's brothers, all males, turn yellow when they get sick or eat certain foods. G6PD deficiency, favism. So you take certain drugs like maybe sulfa drugs, certain antibiotics, or you eat certain foods like fava beans, and then you get the jaundice from that. You get a mild hemolytic anemia. It's as simple as that. This is a fairly benign condition, but it is something that you notice. Okay, so you know it's G6PD. We know G6PD is X-linked recessive. However, you can also figure out that it's X-linked recessive just based on this. So when you're looking at a pedigree and you see that something only affects males, which is the squares, females are the circles, the first thing you should be thinking of is X-linked recessive. Now, another thing that you should notice is that when a male has it, but none of his sons are affected or his daughters, so it's not passed by a male to the next generation, that's also consistent with a X-linked recessive disorder. Because remember, an affected male, he will always pass that X chromosome on to his daughter, so all of his daughters will be carriers, but his sons always get his Y chromosome, and so he won't pass that on to his sons. So all his daughters will be carriers, and all his sons will be unaffected. Okay, let's talk a little bit more about that. So this is X-linked recessive, when to suspect it, but let's take a look here. Okay, so let's say you've got a carrier mother. This is how it would work. So there's a 50-50 chance if it's a son that he's going to be affected, and a 50-50 chance if it's a daughter that she will be a carrier. She's going to get a normal X chromosome from dad, so she would only be a carrier. On the other hand, if the father is affected, as we say, all his daughters are carriers and all his sons are not affected. All right, so how did we get that 12.5%? Well, let's go back here. So what do we know about this patient? Are any of her parents carriers? Yes. So her mom is definitely a carrier. Why? She's got an affected brother. Okay, so he had to get that from mom. Okay, so we know she's a carrier. So we're going to call her XXA. Well, what about the patient here? Is she a carrier? We don't know. We don't know. She doesn't have kids. That's the only way we would know, short of genetic testing. So there's a 50-50 chance she's a carrier. Okay. So there's a 50-50 chance she's a carrier. What's the chance of her having an affected offspring? Well, just do your Punnett square. Here's her husband, XY. Here's her, XXA. So it could be this, could be this, could be this, or it could be this. Well, this is the only one that's affected. So there's a 0.25 chance that the child will be affected, and then there's a 50-50 chance that she is a carrier to begin with. Multiply those, 0.125, 12.5% chance. Now, if we knew she was a carrier, what would the chance be then? 25%. If she were pregnant with a son, what would the chance be then? 25%, because these are the only possibilities. If she said she's pregnant with a daughter, what are the chances? 0. Okay. Now, it's unlikely you're ever going to run into a question where they tell you the dad is affected and the mom is a carrier, but at that point you just need to do your Punnett square. Okay, I had a student a long time ago when I was teaching MCAT for Kaplan, and she had color blindness that was X-linked, and sure enough, both of her parents were colorblind. It can happen with these X-linked recessive conditions, but very uncommon for females to carry them. So here's just a way that you can remember X-linked recessive and some mnemonics. I mean, I wouldn't memorize this unless you really, really want to. The most, what I would say are the most high yield are here that I'm putting in arrows. Fabry's, maybe not. Ehlers-Danlos 5 and 9, no. G6PD, Leishman. So those are the big ones I would remember personally. Hunter's disease, maybe. Usually they'll give you something else for that, though. They have the big dysmorphic faces. Okay, so question 3. A 30-year-old woman presents to the ED complaining of a rash that started on her ankles and has progressed up her legs over the past week. This has never happened to her before. She recently returned from a 2-week camping trip in Wyoming. She has no significant past medical history and takes a multivitamin but no other medications. Vitals are within normal limits. Physical exam reveals a rash as shown. Lab studies are obtained as shown. Let's take a look. But this is going to be our question here. What's the most likely underlying cause of a rash? Okay, here's the rash. Okay, you can pause here. And then here's our labs. You can pause here too. Okay. 4 units of platelets are transfused, and the repeat platelet studies the following day show a platelet count of 12,000 per microliter. Which of the following is the most likely underlying cause of this patient's rash? A, overactivation of the coagulation cascade. B, deficiency of zinc-containing metalloproteinase. C, antibodies to platelets. D, intravascular hemolysis. Or E, infection with Rickettsia rickettsii. All right, I'll take one more look at the rash and your labs. Okay, so we're going to go to our answer here. Oh, sorry. I should make a note of this to myself. Okay, so we do our answer here, and now here's our follow-up question. Based on the most likely diagnosis, which of the following is the best next step in the management of this patient? A, doxycycline, B, corticosteroids, C, plasma exchange, or D, supportive care? Okay, so hopefully you got your answer from the previous one, and now it's this follow-up question. Okay, let's go to our answer for question 3. Oh, did I take it out of here? I must have taken it out. Okay, I'm sorry. So the answer to question 3 is C, antibodies to platelets. Okay, so I must have cut this slide out or something. All right, so it's antibodies to platelets. What is going on with this patient? So she's got a rash, and what does that rash look like? How would you call this rash? I'd call this a purpuric rash. Okay, a purpuric rash. And purpuric rashes are often from platelet deficiencies. So we look then at her labs, and what do you know? Platelet deficiency. Everything else is normal. Coagulation panel, PT, PTT, normal. Fibrinogen, normal. D-dimer, normal. Everything is normal in this patient. LDH, normal. She's not having a hemolytic anemia. Everything's normal except for her platelet count. When you see a patient who's got a normal history, normal physical aside from the rash, normal labs aside from the thrombocytopenia, the smear is normal, what you need to be thinking of is ITP, immune thrombocytopenic purpura, often, at least formerly called idiopathic thrombocytopenic purpura. What this is due to is antiplatelet antibodies, specifically targeting that GP2B3A receptor. So essentially it works the same way as kind of inducing a Glanzmann thrombasthenia or being on tirofiban, one of those drugs that target that receptor. But it is antibodies against GP2B3A, which is important for platelet function. Okay? Now, A, overactivation of the coagulation cascade, what's that? That's DIC. So in DIC, we would expect to see prolonged PT, prolonged PTT, and you would have a thrombocytopenia due to consumption, but those prolonged PT and PTT are going to be critical in diagnosing DIC. We don't see that here, so this is out. Deficiency of zinc-containing metalloproteinase. What is that? That's TTP. What is the enzyme we're talking about here? ADAMTS13. These patients look sick, okay? What about intravascular hemolysis? That's also kind of TTP. So TTP, you've got actual hemolysis going on. So you've got the fever, you've got the thrombocytopenia, but you also have hemolytic anemia, okay, because you've got these clots forming all over in the vessels, and it's going to shear those red blood cells, so you get schistocytes. We didn't see that on the smear. They also tend to have renal dysfunction because of the clotting in the vasculature of the kidney, and they can even have neurologic dysfunction. So that's out. Infection with Rickettsia rickettsii. So that's an interesting one. In this kind of infection, what infection is this, by the way? Rickettsia rickettsii? Rocky Mountain spotted fever. So yes, they can have thrombocytopenia, they can have a rash, and it would start peripherally and move centrally. But the big thing here that we would not see in Rocky Mountain spotted fever is she went from a platelet count of, 19 to 12. Her platelet count went down despite getting transfused with platelets. That's telling you that something is taking those platelets out. That would not happen with Rocky Mountain spotted fever. Rocky Mountain spotted fever, they get a hyponatremia, they get a thrombocytopenia, they get elevated liver transaminases, but if you give them platelets, their platelet count will go up. This patient, you're putting platelets into her, and those antiplatelet antibodies are finding them, they're feasting on them, they're destroying them, and the platelet count just keeps dropping, okay? So that's what this is, antibodies to platelets. So what do? Steroids. Okay, the treatment for ITP is steroids. All right. Don't go for plasma exchange. That would be for TTP. Doxycycline, that would have been for Rocky Mountain spotted fever. If you suspected Rocky Mountain spotted fever, if you saw elevated transaminases and hyponatremia and platelets went up after transfusion, and maybe she had a fever, and you thought Rocky Mountain spotted fever, you're going to get serology. Are you going to wait for serology to give doxycycline? No, you're going to give doxycycline first, and then your serology will come back. But there was no reason to suspect Rocky Mountain spotted fever here because her platelet count dropped further after giving her platelets. So it's a telltale sign you got an antibody. Supportive care. Okay, we're going to go into that. All right, this is important. Okay, so ITP rather, we talked about the etiology, the clinical findings you're going to see, the lab findings you're going to see. The treatment is what's going to differ whether this is a PEDS question or an adult medicine question. So in PEDS, ITP tends to be self-limited. The treatment is going to be based on their symptoms and their symptoms alone. If they only have cutaneous symptoms, i.e. they only have a rash, go ahead and observe, regardless of the platelet count. On the other hand, if they have mucosal bleeding, so they're bleeding from their nose, they have bleeding blood in their urine, they have blood in their stool, then you have to treat. And the treatment is steroids, IVIG, or anti-D. And that anti-D is only given if the patient's Rh positive and has a spleen. Okay, so these are your treatments, and they're going to be the same whether it's a child or an adult. Now, in adults, we base the treatment on symptoms and the platelet count. Okay, so in adults, if they have cutaneous symptoms or no symptoms, but cutaneous symptoms and their platelets are over 30, you can observe. However, if they have mucosal bleeding, just like in kids, or if their platelets are under 30, regardless of symptoms, you have to give steroids. Steroids are the best initial treatment. If that doesn't work, then you can do IVIG or anti-D. That is second line. But steroids are first line for ITP that needs to be treated. If that's not enough, there are other treatment modalities, rituximab, splenectomy in very refractory cases, but your first line treatment for ITP is steroids. However, you need to know, when do you observe, when do you treat? And it's different in children and adults. In children, it's purely based on symptoms. In adult, you have to consider treating even if they don't have symptoms, if their platelet count is very low. Oh, and then note here, sometimes this can be preceded by a viral infection. Okay, question 5. A 62-year-old woman presents to the clinic complaining of intermittent chest palpitations, shortness of breath, and insomnia for the past 3 months. She also says she's lost 8 pounds without trying. Past medical history is significant for dyslipidemia and carpal tunnel syndrome. Medications include simvastatin, low-dose aspirin, and CoQ10 supplement, which is over-the-counter. Vitals show blood pressure 138/73, heart rate 109, respirations 14, temperature 99.1, and I guess I failed to convert that to degrees Celsius. Between 37 and 38. Physical exam is notable for a fine tremor in both hands and mild enlargement of the left side of the thyroid gland. EKG shows sinus tachycardia, chest x-ray is unremarkable, BMP and CBC are within normal limits. TSH is less than 0.01 and free T4 is 3.2. Which of the following is most likely to be the appropriate sequence of further diagnostic evaluation in this patient? A, RAAU scan followed by ultrasound-guided fine needle aspiration. B, RAAU scan followed by elective surgery if indicated. C, ultrasound followed by elective surgery if indicated. D, ultrasound followed by RAAU scan. Or E, ultrasound and fine needle aspiration. Okay, so this is going to be followed up by another question, and then we'll move on to talk about both of these. Based on the imaging results shown, aside from symptomatic management, which of the following is the best next step in the management of this patient? Let's take a look at the imaging. Okay, so here's your ultrasound and your RAIU. And I realize now, looking back, I said, okay, I did say left, right? Okay, yeah, all right, so this is left. All right, so here's your imaging. Now let's go back. Which of the following is the best next step in the management of this patient? A, methimazole followed by radioactive iodine. B, total thyroidectomy. C, propylthiouracil followed by radioactive iodine. Or D, continue symptomatic management and recheck TSH in 8 weeks. Okay, so we're gonna go and look at our answer to question 5. So 5 is ultrasound followed by RAIU scan. You probably figured that out based on the imaging that I showed you. So what are the first 3 things that we always do when we have a patient with a thyroid nodule? Palpable thyroid nodule, an enlargement, whatever you want to call it. Physical exam, thyroid function tests, at least including TSH, and thyroid ultrasound. Okay, you always have to get these things when you've got a patient with a thyroid nodule or any kind of mass of the thyroid. Always, always, always. Those 3 things, absolutely mandatory. Okay, so if you haven't gotten a thyroid ultrasound, get one. If you haven't gotten a TSH, get one. Well, what has she had so far? She has had, looks like she's had her TSH done. Okay, that's done. She had a physical exam. Now she needs a sono. Okay, well, which of these have sono? This doesn't, this doesn't. Okay, so now she gets a sono. What is that sono likely to reveal? She's got a mass on the thyroid, and she's got a suppressed TSH. That's probably going to show a mass on the sono. And when you see a mass on the sono, and it is a functioning mass, okay, meaning you're getting thyroid hormone from somewhere, so it's probably functioning, what are you going to need to do? You're going to need to determine whether this is truly a hot or a cold adenoma, functioning or not functioning, and the way we do that is RAIU scan. We have to do that. We don't ever just go in with an ultrasound, see something, and then take it out with a partial or complete thyroidectomy. We never do that. And ultrasound of fine needle aspiration, this would be good if her TSH was in the normal range. We could do that. So let's just look here real briefly before we go to our answer for the previous question. So like I said, clinical evaluation, TSH level or thyroid function test, and an ultrasound. Okay, if there's no cancer risk factors or suspicious ultrasound findings, then you look, is the TSH normal or high or low? If it's normal or high, that's telling you you're probably dealing with a non-functioning nodule. That we get concerned about for cancer. So we do a fine needle aspiration rather than scintigraphy. If the TSH is suppressed, as in this patient, we do the scintigraphy. By the way, this is the same as RAIU, radioactive iodine uptake. So then we go to the RAIU. So we did the ultrasound, and then we're going to go to the RAIU. Why? Because the TSH was low. We already knew that in this patient. If the nodule is hot, meaning increased uptake, you treat the hyperthyroidism and then elective surgery. If the nodule is cold, fine needle aspiration, concerned about cancer. Fine needle aspiration is what we do when we're concerned about cancer. All right, so ultrasound followed by RAIU scan. Ultrasound fine needle aspiration, that would be good if the TSH was high or normal. It's not. Now, to treat this, what do? Well, we're dealing with one nodule here, not multiple. When you're only dealing with one, you could do surgery, or when you're dealing with an older lady like this, you could also do radioactive iodine ablation. Now, if this patient were to get surgery, what kind of surgery would we do? Would we take the whole thyroid out? Absolutely not. We would not take the whole thyroid out. The only time we really jump to taking the whole thyroid out is if they had a multinodular goiter, so they had multiple toxic adenomas, or if they had malignancy, or if they had such a terrible goiter that it was causing obstructive symptoms. That's the only time we take the whole thyroid out. If you just have one nodule, we can take that nodule out. So we would never do a total thyroidectomy in this patient. What about continued symptomatic management and recheck TSH? No, we got to treat the underlying cause here. So now we're just between methimazole or PTU followed by radioactive iodine. Which one is preferred? Methimazole is preferred. When do we prefer PTU? First trimester of pregnancy. Okay, that's pretty much the only time we really prefer PTU. Methimazole is generally cleaner. Okay, so it is methimazole followed by radioactive iodine. So this is a toxic adenoma that we see here. We kind of went through all these things. So look for that focal increased uptake. And you also need to know what RAIU is going to look like for all your disorders here. So great. Here's, oh no, they don't put normal here. Okay, so this is normal kind of right here. So here's what we saw in this patient, the hot nodule. It's a toxic adenoma. You just see one little discrete focal area of increased uptake. Toxic multinodular goiter, it's very similar, but you have multiple nodules. Graves' disease, you see increased uptake, so compare this to this, but it's confluent throughout the thyroid. A cold nodule, you would see an area of decreased uptake as opposed to an area of increased uptake. And an autonomous nodule is where you have a nodule that's working so hard and on its own, it's secreting thyroid hormone that it suppresses the rest of the thyroid tissue. And then thyroiditis, this is an important one, RAIU is going to be very, very low. Okay, and this is important that you know this because thyroiditis can have a hyperthyroid phase. In that case, you need to be able to distinguish it from Graves or distinguish it from nodule. So, if you're dealing with a lymphocytic or a postpartum thyroiditis, they can have a hyperthyroid phase and you might get the RAIU not knowing what you're dealing with. And this would tell you right here. This is destruction of the thyroid. You can have a hyperthyroid phase. Okay, question 7. The patient is informed of the risks and benefits of the benefits and risks of a procedure. I guess I should say A patient is informed of the benefits and risks of a procedure and is prepared under sterile conditions. After administering local anesthesia and while the patient is positioned supine, a tunneled catheter is placed through the basilic vein and is successfully advanced to the junction of the superior vena cava and right atrium. The catheter is secured using a sterile adhesive dressing and is flushed to confirm patency. Subsequent chest x-ray confirms the catheter is in the desired position. Compared to a similar procedure that obtains access via the internal jugular vein, which of the following is a major disadvantage of the type of venous access this patient underwent? A, increased risk of infection. B, increased risk of thrombosis. C, increased risk of intraoperative complications. Or D, higher patient discomfort. Oh, this is a tough one, isn't it? You're probably thinking, man, that looks like a surgical note. Well, it kind of is. Okay, let's go ahead and answer this one. Increased risk of thrombosis. What is being inserted here? This requires you to know a procedure. And they're telling you what they're doing, and you need to know what is going on. What are they doing here just by looking at the procedure that's happening? What is being inserted here? What is this that's being described? This is a PICC line, peripherally inserted catheter. Okay, so this PICC line here has a number of advantages compared to what's down here, a similar procedure that obtains access via the internal jugular vein. That's a central venous catheter, a central line. Okay, so these are two ways of being able to administer drugs, either in the hospital or long-term. Maybe you're talking about a patient who needs to receive chemo or something like that. Okay, CVC and a PICC line both have their advantages and disadvantages. PICC tends to have more advantages, but it's got one big disadvantage. And what is that disadvantage? Thrombosis. You know, because the answer is right here. Why thrombosis? Why do PICC lines have an increased risk of thrombosis? Here's a PICC line here, right? So PICC lines are much longer. Obviously, if you're going up through here, you don't need as long of a line. These veins here are also smaller. So you've got a longer line, you've got increased catheter to vein diameter ratio. There's more contact with vascular wall. So as the line is in the vein, it's just coming up into contact with the wall of the vessel. It can damage the endothelium, and that can cause thrombosis. Okay. Also, it doesn't take as much thrombosis because the veins are thinner, and so or smaller. So what is the big problem then? You get thrombosis of the upper veins. What can happen? An upper extremity DVT. You can get a deep vein thrombosis from this, okay? You'd expect to see all the same things as you would see with a lower DVT, swollen arm, and you can, of course, get pulmonary embolism and stuff. So that can all happen from this. However, the other things are advantages to PICCs. So lower risk of infection, lower risk of procedural complications like a pneumothorax or carotid injury. And it does tend to be more comfortable for the patient just based on where the line is at. Okay, showering is easier, bathing is easier. Okay, so it is increased risk of thrombosis is the big downside to a PICC line. That is the takeaway here. Okay, so here's the PICC line. Here's the CVC, central line. Okay, question 8. A 19-year-old woman presents to the clinic complaining of acne on her cheeks and forehead that has stopped responding to over-the-counter treatment. She's been using topical salicylic acid, which worked for her throughout high school, but now the acne is getting worse. She has no significant past medical history and is on no medication. She doesn't drink alcohol, smoke, or use recreational drugs. She says, "My only addiction is chocolate." She's sexually monogamous with her boyfriend. Menstrual periods are every 28 days. Vitals are within normal limits. Physical exam reveals scattered comedonal acne on her face and upper back. No hirsutism. Remainder of the exam is unremarkable. Which of the following is the most important information to ascertain from this patient? A, plans for future pregnancies. B, extent of her chocolate consumption. C, personal history of antibiotic allergies. D, family history of polycystic ovarian syndrome. Or E, personal history of recent weight gain. Okay. The answer plans for future pregnancies. What does this patient have? She's got comedonal acne. Okay, comedonal acne. What do we do if we are going to be giving something to a patient for acne? What is the very first thing we do that everyone gets when we start treating them for acne? Topical retinoids. Okay, tretinoin. Wonderful, wonderful drug, by the way. Lots of people take it just for just to make themselves look better. It will really rejuvenate your skin. It's really incredible, but it is used primarily for acne. Okay, so tretinoin is a topical retinoid, and it is pregnancy class C, which means proceed with caution. It's like your yellow light. A and B are safe. D and X are avoid. X means never use, okay? So I should put that, pregnancy classes. A, safe for use. You got to know this, by the way. B, likely safe. So A is safe for use because they have human studies proving it. B is likely safe. C is only if benefit outweighs risk. D is only in extreme circumstances, i.e. mom's life depends on it. And X means never. So tret is right here. Your retinoic acid derivatives are right there. The one that's down here, which is also a retinoic acid, that would be the oral retinoic acids. That would be like isotretinoin, Accutane. It would also include tazarotene. That's also pregnancy class X. So we need to know this because we're going to be giving her something pregnancy class C. We want to know if she's planning on getting pregnant, because if the answer is, yeah, I want to get pregnant like now or next year or something, then we need to tell her, okay, we should probably not use these drugs while you're pregnant, deal with the acne for now, and then once you give birth, we'll go forward from there. But let's look at these other ones. Extensive chocolate consumption. Is chocolate associated with acne? No, old wives' tale. Personal history of antibiotic allergies. Are we going to antibiotics right now? No. We'll talk about treatment in a little bit. Family history of PCOS. Does she have PCOS? No. Menstrual periods every 28 days. No complaints of weight gain. No complaints of hirsutism. She doesn't have any of that. Personal history of weight gain. If we were thinking Cushing's, maybe Cushing's can cause acne, but Cushing's would also cause hirsutism. It would also cause the patient to be very overweight, gain a lot of weight recently. It would cause other skin problems, so that's not it. So you should know the difference between the different kinds of acne. So comedonal is non-inflammatory. It's not going to be red. Primarily what they're going to have are whiteheads and blackheads. Okay, so I have a picture of that here. Notice there's not a lot of redness. Now this patient does have some papules, here and here. But you can see there's not a lot of redness, not a lot of erythema. This is not inflammatory acne. This is comedonal acne. Papulopustular or inflammatory acne, you see a little bit more redness. I apologize, these pictures aren't that great. Oh, here we go. Okay, so here you can see just not that much redness because it's not inflammatory. Whereas here you see your papules here, or nodules. Only difference is this is more than 5 millimeters. And you see surrounding erythema. That makes it inflammatory. So papulopustule is inflammatory, and then nodular is also inflammatory. The only difference is the diameter, okay? So we go in then for treatment. Comedonal acne, well, really any of these, you'll start with topical retinoids, okay? But comedonal acne, we just do the topical retinoids. That is where we start. That is this patient. We're going to send her home with tretinoin, and she's good to go, okay? Now, if it's inflammatory acne, then we start with topical retinoids and benzoyl peroxide. You can get benzoyl peroxide over the counter, okay? Now, with anything, well, let me back up here. Nodular or cystic acne, we start with topical retinoids, benzoyl peroxide, and topical antibiotics. So clindamycin, erythromycin. Often you can get these two together. It's called DUAC, clindamycin, benzoyl peroxide. Okay, so that's where we start. But you can also think of this in another way. You can think of this as like a step up. Okay, so when we have moderate papulopustular inflammatory acne, then we start the same as we would when we start with nodular or cystic acne. Okay, so just look at these as just steps up. Topical retinoids is where we start with comedonal acne. Topical retinoids plus benzoyl peroxide is where we start with inflammatory acne, but it would also be appropriate to go there with comedonal acne if the topical retinoids are not enough. And then from there, we add the topical antibiotics, and then from there, we add the oral antibiotics. And then if none of that works, then we do the oral vitamin A derivatives, the isotretinoin, PO. And we would stop everything else, except for, maybe some, cleaning your face and stuff like that. But this would be done on its own. Now, by no means is oral isotretinoin limited to cystic acne. You can use it in inflammatory acne if you fail all this other stuff. Okay? So remember what you should remember here is the order, the sequence. So topical retinoids for everyone. Then benzoyl peroxide, then topical antibiotics, then oral antibiotics, then oral Accutane. Okay, now the topical antibiotics, that's typically going to be, like I said, erythromycin, clindamycin. The oral antibiotics, doxycycline is typically given. Doxycycline, all right? So here's your pregnancy class for all of these. It is important for you to know this. When you are dealing with a female patient who has acne, pregnancy is commonly going to be asked. If she does need one of these pregnancy class X drugs, what she needs to be on effective contraception. That means an IUD, that means oral contraception. It does not mean condoms. It doesn't mean a dam. It means medications. It means taking oral contraceptives, combined oral contraceptives, the mini pill. It means having an IUD placed. It means a Depo-Provera, something medical done to prevent pregnancy as opposed to, condoms. So they have to be on that. They need to get a pregnancy test every time they come in. That is mandatory when you're dealing with Class X. The rest of these, though, it's really just kind of play it by ear. All right, so if she's on oral tetracyclines, you'd probably want to advise her, don't get pregnant. If you're going to get pregnant, stop the drug. But you can see these kind of follow a path. They get more dangerous the later you use them, okay? And then here's another chart that I found online. I would stick to what I told you, but what I wanted to point out here is that for females, there is a different regimen that they can use. They can use anti-androgens, something like spironolactone. And the reason they can use that and boys can't is that we don't want to use anti-androgens in a teenage boy. We want him to have those androgens so he can, grow into a man. Whereas for females, that's not as much of a... Okay, let's move on to question 9. We got a 32-year-old man brought into the ED via EMS, accompanied by his roommate due to abnormal behavior for the past 2 hours. The roommate found the patient slamming his own body against the wall, and when the roommate confronted him, he became aggressive and began yelling at the roommate as well as people who weren't there. The roommate called 911, and the patient was restrained by law enforcement and brought to the ED. According to his medical records, the patient has a history of bipolar II disorder, which was diagnosed 10 years ago and prescribed lithium. He has not filled his medication for several months. The roommate says that the patient occasionally drinks alcohol and does not smoke tobacco, but is unaware of whether the patient uses any drugs. Patient recently went through a breakup with his girlfriend and has been down. Vitals show blood pressure 148/94, heart rate 110, respiration 16, temperature 98.6. On physical exam, the patient is agitated and tells you, "They're telling me you're trying to take my money." Pupils are dilated and are reactive to light bilaterally. There is mild horizontal nystagmus. EKG shows sinus tachycardia. Which of the following is the best next step in the management of this patient? A, propranolol, B, lorazepam, C, activated charcoal, D, isolation in a low stimulation room, or E, psychiatric consult. Okay. So this is one of those kind of psych versus medicine questions. Let's go ahead and look at the answer here. So is lorazepam. All right, now when you're approaching this question, I'm sure the very first thing you're thinking of is that this is probably a manic episode. And you've got a patient with bipolar 2 disorder who hasn't filled his medication and now he's aggressive. That is certainly a reasonable first place to think. However, with manic episodes, expect to see those dig fast symptoms, delusions of grandeur. They're coming in, they're telling you they're the king of England, where they have insomnia. They haven't slept in a long period of time. They have a flight of ideas. They have psychomotor agitation. They're not sitting still. We don't really see a whole lot of that in this patient. I mean, we see that he is aggressive, but there's a number of things that can cause you to be aggressive, drugs being one of those things. Now, one of the things that really cue us away from just an ordinary manic episode is the fact that this patient has objective symptoms. He's got mydriasis, he's got hypertension, he's got tachycardia, he's got nystagmus. None of that is going to happen in a pure manic episode. Now, when you have psychiatric symptoms plus objective features that you see on physical exam, and especially when it is in a young person, a male, somebody with a psychiatric history, you got to think drug use. Psychiatric history and drug use go hand in hand. Okay, so don't be distracted by the fact that they say bipolar disorder doesn't mean he's having a manic episode. What that could tell you is that this patient has a risk factor for illicit drug use, and he certainly does. He's a young man. He's got a psychiatric history. He went through a breakup. I mean, all of that just spells this guy may be on drugs. And when you see nystagmus, nystagmus, which is where the eyes are beating to one side or the other, plus aggression, what are you thinking? What drug? Phencyclidine, PCP, or angel dust. That should be the first thing that you're thinking. Now, when you have a patient who's aggressive, you got to treat that now, not only for the safety of the patient, but for your safety. And there's 2 drugs that we can go towards when we need to treat an aggressive patient, and those are benzodiazepines or antipsychotics. Now, if haloperidol, for instance, was an answer choice here, that could be correct. However, it's not. And so the other drug is the benzodiazepine. That's lorazepam, and we can go with that. Now, propranolol, that would treat the high blood pressure, but that would not treat the aggression. It would not treat the nystagmus. It would not treat the underlying cause. Now, lorazepam's not really going to treat that either. But propranolol, beta blockers, while they're mildly sedating and they're mildly anxiolytic, they're not going to make a dent here. Okay, so that's out. Activated charcoal. Activated charcoal is good for preventing the absorption of drugs that were recently taken. I would say anything less than a couple hours would be okay to try activated charcoal. We're still going to need to provide this patient with medications to help his symptoms. But because this patient took these medications at least 2 hours ago, charcoal is not going to help. Low stimulation room, that's good supportive care. We could do that in addition, but by itself, it's not going to be enough. Psychiatric consult, no, we know what's going on here. Okay, so it is lorazepam. Now, here is a table of some of the illicit recreational drugs and some of the things you can see here. I put the most important stuff in bold. Make sure you know how to identify marijuana intoxication, because marijuana is becoming legal in many states. You're going to see this more and more. You're going to see pediatric ingestions because a lot of these marijuana, they're gummies, so they look like candy and kids can get into it. Look for the conjunctival injection. Look for, you could be anywhere from euphoria, sedation, to dysphoria, panic, can be any of those. Increased appetite can also be seen. There's really no drug that you can give to really help with cannabis. You just treat it symptomatically. Reassurance is good. That's where the low stimulation room can come into use here, because a lot of these patients are going to be paranoid. You can use antiemetics. You can use benzodiazepines as well, though most of these patients aren't going to have objective features of sympathetic hyperactivity. Opioids, really kind of the different one here. This depresses you. It's a downer. Depressed mental status. Respiratory depression is a really, really big one that you need to look out for. So you want to make sure we're monitoring these patients, have naloxone, have intubation equipment at the ready in case you need to use it. The stimulants we talked about. It is worth knowing that these stimulants are going to cause objective signs, tachycardia, high blood pressure. So these are good to know. Now, cocaine versus meth, is it important that you be able to distinguish the two? Not really, because the treatment is more or less the same. You're going to use benzodiazepines for the objective signs, and I know I've told you many, many times, and I want you to remember this. When you're dealing with a cocaine overdose, do not use beta blockers. There is some evidence that carvedilol can be used, but on your exam, do not pick beta blockers. If remember, cocaine, these stimulants have both alpha and beta stimulation activity. If you block the beta receptors, you're going to have unopposed alpha stimulation, which can worsen your condition. Hallucinogens, of course, they're going to hallucinate, but the big one with PCP, the nystagmus, that's really going to help you there. Unlike LSD, these patients can become violent. Benzodiazepines or antipsychotics are fine. Okay, let's finish up with question 10. A 19-year-old woman presents to the clinic complaining of worsening difficulty breathing for the past month. She says that she has episodes of cough, shortness of breath, and chest tightness, and these episodes are occurring almost every day. These episodes began last year when she moved from Arizona to Texas for college, and she never had these episodes before moving. Past medical history includes migraine and celiac disease. Her migraines have been worse over the past week, which she attributes to poor sleep due to studying late and frequent practice for the swim team she's on. She gets relief from ibuprofen, which she says she takes once or twice per week. Medications include sumatriptan and dancetrone and ibuprofen, all as needed, as well as folic acid daily. She doesn't smoke, drink alcohol, or use drugs. No other complaints at this time. Vitals are within normal limits. Physical exam reveals bilateral scattered wheezes, no nasal polyps. Chest x-ray is unremarkable. Pulmonary function testing is performed and is as shown. Let's take a look at our PFTs. So here we have it. Okay, let's look at our answer choices. In addition to appropriate pharmacotherapy, which of the following would be most useful in mitigating this patient's symptoms? A, measures to control house dust mites. B, daily loratadine. C, discontinue ibuprofen. D, discontinue swimming. Or E, immunology referral. Okay, let's take one more look at those PFTs, and then we'll move on to our answer. Our answer. Okay, so here's our PFTs, and let's go to our answer. Measures to control house dust mites. All right, so we got a young woman, difficulty breathing. They come in episodes, and it's a cough, shortness of breath, and chest tightness. When you hear cough, shortness of breath, and chest tightness in a young person, it comes in episodes. What are you thinking? You better be thinking about asthma. Hey, that should be number one on your differential. And so when you suspect asthma, of course, you want to rule out all the other possibilities of, not all of them, but rule out the major possibilities of shortness of breath. But in a young person, it should be pretty straightforward. You know, one of the things you might want to think of with a chronic cough is the possibility of reflux, but she's not complaining of burning sensation. It's not coming with meals. It's not at night. It's not waking her up. So that kind of points us away from reflux. But you always need to be thinking about reflux with chronic cough. So what do we know about these episodes? Well, she never had them until she moved. Okay, that's interesting. Maybe it's allergic. Well, what is it allergic to? I mean, she moved from Arizona to Texas, fairly similar locations. So it's probably not an outdoor allergen. It is probably an indoor allergen. What happens when you move from one state to another? You move into a different house. And depending on the house you move into, is it old? Is it new? If it's an older house, there might be mites, there might be cockroaches, there might be bugs that can cause asthma. So house mites, like the dust mites and the cockroaches, they are all allergenic. And as a matter of fact, indoor allergens, 80% of people with asthma are sensitive to indoor allergens. Now, we can't control pollen. We can't control anything outside. You can control, though, what is inside. And so you should be making your house, or at least your bedroom, as hypoallergenic as possible. That means cleaning your sheets. That means not drying your clothes outside. That means using a filter. Various things that you can do. So these are the measures to control house dust mites. Now, when you're 19, you can't afford necessarily to have your whole house renovated. You can only go so far, but do what you can to control these mites. Now, daily loratadine, that is more useful for allergic conjunctivitis, allergic rhinitis, not going to help a whole lot with asthma. Discontinue ibuprofen. Can ibuprofen cause asthma? Yeah, it can increase your risk of asthma attacks. Now, remember how this happens. Remember, we have arachidonic acid, and that could get shunted into via the COX enzyme into making prostaglandins, or by the 5-lipoxygenase enzyme to make leukotrienes. So if you block COX, everything's going to get shunted to leukotrienes, and that raises your risk of asthma. However, she's had migraines for a long time. She's been on ibuprofen for a long time. And this asthma just started when she moved. Furthermore, she's not on ibuprofen every day. She's taking it once or twice a week, but these episodes are every single day. So that's out. Discontinue swimming. You're probably not going to have an asthma attack from swimming. If this were exercise induced, we might think, okay, maybe it's associated with the swimming. If she's saying she's having the attacks after she gets out of the water, or she's having them while she's in the water, but this is probably not it, because if there would be a very clear association with the exercise. That's how exercise-induced asthma works. So that's out. Immunology referral, no, we don't need to do that. We know exactly what we're doing here. So it's control the dust mites. So dust mites and cockroaches are the big cause of inhaled indoor allergens. Animal dander, do you have cats, you have dogs, that can do it. Pollens and molds, they can get into the house. So, measures you can take there, keep your doors shut, air conditioning on. I have to keep my air conditioning on all summer because I have asthma. And you go outside and May, June, it's pretty nasty. So there are a number of things they can do, but you got to control your indoor inhaled allergens. That comes first. Respiratory irritants, cigarette smoke. She doesn't smoke. Air pollutants, you really can't control that. Perfumes, we don't see anything with that. We talked about aspirin and NSAIDs. Non-selective beta blockers. Remember, your bronchi, they've got beta receptors all over. When those beta receptors are stimulated, the bronchi dilate. That's the whole point of using albuterol for asthma. If you're taking a beta blocker, it can make your bronchi more susceptible to spasm because you're blocking the beta receptor. So you want to be very careful with beta blockers in a patient with asthma, but she is not on that. Other things, upper respiratory tract infections, reflux disease. So if that's something you would want to exclude here, typically these will happen at night when they're sleeping, wake up, short of breath, wheezing. It's highly associated with laying recumbent. That's typically how reflux works. But remember reflux on your differential of chronic cough, which she certainly has. Exercise, we talked about cold and dry air. She ain't having that in Texas. Maybe dry, but not cold. And furthermore, again, here we see that when she moves into a new house and she's having these episodes. We really got to be thinking this is something environmental. Yes, it would be useful to take maybe a daily medication, take your salmeterol, inhaled corticosteroid, but you've got to control the indoor allergens. That means getting rid of any pets if that's the problem. But the big thing is washing your clothes, washing your laundry, using a HEPA filter. All of that stuff is going to go a long way in preventing these attacks from happening.